Hello, everyone, and welcome to today's podcast. It is MR Safety Week 2024, and we are doing something just a little bit different this year, something that I don't think MetroSense has ever done. The new ACR Manual 2024 was just released, and I have invited 3 technologists to join us today to chat a little bit about how this is impacting their workflow, their MR safety practices. So I'm going to take a moment. I'm going to introduce everybody. Let me start with myself. I'm Kellye Mantooth. I am the National MR Safety Trainer for MetroSense, an MR Technologist, Certified MRSO, and MRSE. And joining us today is Kris Seitz, John Reyna, and Randy Parker. Kris, I'm going to let you go first, if you don't mind, just to tell the listeners a little bit about you.
Absolutely. I'm Kris Seitz. I'm an MRSO, MRI technologist for Ohio Health in Columbus, Ohio. I was the first MR safety officer at my organization, and it didn't kill me. So I've got about 10 other technologists that have joined on. At my site, we've got 3 magnets. We've got a 3T, a 1.5, both of those in the hospital. And then we have an outpatient center that has a 1.5 also. When I'm not scanning, I'm on the board of directors for the ABMRS. I am active with the ASRT as an MRI delegate, and I'm the current president of the Ohio Society of Radiologic Technologists.
Perfect. All right. I'll move on. John Reyna, I'm going to let you go next if you'll tell the listeners a little bit about yourself.
Sure. I have been in medical imaging for over 30 years. I've been in a variety of different roles, worked at large tertiary care academic centers. I am now at an outpatient imaging center, and I'm the one technologist operating one magnet at this point. I am an MRSO, MRSE, as well as being a board member of the ABMRS. So, yeah, this is a lot of fun to be part of this.
Thank you for joining us. And then last but certainly not least, Randy Parker, if you'll tell the listeners a little bit about yourself.
Sure, yeah. My name is Randy Parker. I am the lead MRI safety officer at Corewell Health West, which is based out of Grand Rapids, Michigan. I've been in that role since April of 2021. It is a dedicated full-time MR safety officer role. So it allows me to really be hands-on in the oversight and implementation of safety practices within our healthcare system, which includes staff education as well as educating, first responders and the likes. We have 17 MRI locations, about I think 20. We're up to 22 scanners now. We have everything from mobile outpatient sites to level 1 trauma hospital centers. We even have a intraoperative MRI suite that we oversee as well. So myself and my team are responsible for clearing the complex medical devices that get scheduled, as well as coordinating care for those devices with the different vendors or physicians that may be needed depending on what the device is. I've been MRSO certified through the American Board of Residents of Magnetic Resonance since 2019, and I've been in MRI since 2015. Thank you for having me on today.
Yeah, thank you guys for joining us. So one of the things that I hope that our listeners will take away from this is that we have a variety. John said he works at a facility with 1 magnet. Kris, you said 4 magnets, correct?
We've got 3 at my site.
Okay.
2 at the hospital,
and then Randy,
and 1 across the street.
Okay. And Randy, you said, remind me again, how many magnets do you guys have? 22?
22, but of course I'm willing
22.
to share.
I think people will want your staff more than your magnets right now, but we can get to that.
Yeah.
So what I hope that our users will take away from this, though, is that we have a variety. So if you're a technologist and you're listening to this, I hope that you'll find something here for you today. So we're going to talk a little bit about the new ACR manual, how that's affecting each of your facilities. So I think the place that I want to start is, what were your first thoughts? So we waited a minute. The last manual came out in 2020. We know in 2023 there was a draft that they opened up for comment. And then they just recently released the 2024 version. So what were your all's first initial thoughts when you saw the 24 version?
Honestly,
I would say, go ahead,
that
Kris.
there was a PET CT scanner on the cover of it.
Fair. That's fair. John,
Yeah.
what were you going to say?
I was going to say that just the structure and the formatting, I have seen a lot of change and improvement, and the organization and presentation definitely very different than it had been in the past, but also the appendices. I think Appendix 4 as a really strong resource and tool, that just really got my attention. I was pretty impressed with that.
Yeah, I agree. Rainey, what about you?
Yeah, I got to echo what Kris and John said, but also add just the amount of detail that has gone into this version. The how granular they got in their recommendations for a given hospital site. It just seemed like it was very well thought out. It seemed like it was very well. They took the I think I read somewhere there was like 700 and something comments that were submitted during that open period.
Yeah.
And they really just seemed to, I think, kind of grasp the variety of environments, MRI environments that they that these guidelines can apply to. I also think that they got clearer for certain things, which I thought was very, very important. And I also love that they included pictures. Who doesn't like pictures?
Yeah.
So I mean, you have great examples from the Magnet Vision app that Dr. Canal had. There were screenshots in there discussing or showing examples of the different fields within MRI. So just different things like that. I thought really caught my eye as well.
Yeah. I think for me, one of the first things that I noticed whenever I looked at the new manual, so I took my MRSO test in 2019, and the version that I had to study off of was like, it was nothing compared to this. And so my big takeaway was like, man, where was this at when I was studying? I feel like it's a really, I'm not going to say that you can read this manual and be like, I'm going to pass the test, but it's a great resource, much better than whatever I was using, which was what I think the 2013 version. Yeah, I think 2019. No, yeah, 13 or 19 one. But I thought this version, like if you're looking for a resource to study off of or to learn more before you dive into other material, I thought it would be a great place to start. So I'll move into a little bit of the changes now, and we'll see if that's affected you guys any or what you guys are doing to accommodate. So probably one of the biggest ones that I think we saw a change in prior to this manual coming out, but we've moved away from this 5 gauss boundary, and now we've moved to 9 gauss. Is that changing anything for you guys?
It hasn't changed anything for our practice in particular, just because we are very selective about what we take into the room. So we don't have anything that could go up to the 5 gauss line or the 9 gauss line. We don't have anything tethered. About the only thing that comes into the room from the outside, IV pumps and our travel vents that our patients come down on, and those things, the 5 gauss line wasn't an issue for that. I can see where for intraoperative or for more patients that require more equipment, more accessories, that would be a big deal. But yeah, it hasn't really changed anything for us yet.
Yeah. What about you guys?
At my site, that really hasn't had any effect overall. The configuration and the room design were pretty much inclusive of that being in zone 4 anyway. So it was really no big change significantly for my.
Yeah. Now, Randy, you said you guys have an intra-op. Is that right? An intra-op MR? Yeah. Did it
Yes.
change anything for you
Yep.
guys within that intra-op MR or any of your other scanners? You've got 22, so it's likely it affected one of
Right.
them.
Well, as far as the interop, no, because it's not one of those that where they have the scanner on the track and it would go into the OR room. It's a stationary magnet, so the patient goes from the OR into the MR suite in zone 4. So it hasn't really changed anything as far as that. There is actually a scenario in which the 9 Gauss line actually did play a role, and that actually had to do with the floor underneath one of our scanners. Underneath our 3T, they were doing some construction work, renovating an office space. And they were up in the HVAC area, and the construction worker's screwdriver got stuck to the cement ceiling. And then all of a sudden, they told their coworkers about it, and then we go in there the next day, and there's screws and paper clips and all kinds of stuff stuck to the ceiling. So we thought, okay, we probably need to kind of measure this out. We had a physicist come in and actually measure the Gauss with a Gauss meter, and we had to put up signage, basically just kind of showing where that 9 Gauss line is, just in case for anything in the future, if somebody needs to go in there and work in the HVAC system and they have a pacemaker or something like that. We had to mark off that area. So ironically enough, yeah, it did actually have a pretty significant impact on that.
Yeah, I think you're on
Oh,
mute.
I think she's.
She
Can you
is.
guys hear me now?
Yes.
Yes.
Okay.
There you
This is my first time. I'm just kidding.
go.
But so similar to you, Randy, in my role prior to this, I was the lead MRSO at a level 1 trauma unit. And where that came into a big play for us was we had a couple of magnets that we decommissioned, one of them quenched, and the other one just we needed to replace it. And so we had a lot of construction workers that were up on the ceiling, and our 5 Gauss expanded out past that. So I could see what you're saying and how that would play into it. Now I would be curious to go back and measure that and see if it, if it changed anything, if we could be less restrictive. But anyway,
Yeah.
so some of the other
Well, of
changes
course,
that have,
in that scenario,
go ahead.
sorry, I was just going to say, of course, before that incident happened, we had no idea that that the magnetic field even bled down into that far. But it was an older system, and so it was
Yeah.
something that was, when it was installed, they weren't really thinking about it, and so there wasn't anything in place to mark a 5 Gauss line at that point. But we knew that the standard had changed to 9 Gauss, and so we went with that.
Yeah. And so I guess for our listeners, that's something that they could be considering. If you have something above or below, or if you have people that are coming in and out, maybe that's a good thing to demarcate and to just be aware of that, hey, we might get some interference if you have an implant and you come into this area. One of the other things that I think is a popular topic right now with the new manual are the personnel recommendations. I know, John, you said specifically you're at an outpatient facility and you said you're the lone technologist, like you're a one-man show out there. Did I get that right?
Yes, that is correct. So I am at a very well designed facility that has a front desk person, and we have a suite that is a shared control room for zone 3. So many places not necessarily the ideal for MR as far as what you would see, but practical as far as this outpatient imaging center. The beauty of it for me is that my coworkers who do X-ray and CT are level 2 trained, and so they serve as my second person, kind of making sure no patients would ever come into zone 3. But I am the one MRI tech, and I do 10 patients a day. I'm on 45-minute time slots, so it's a pretty steady pace through the day. Certainly one of the best things I think that helps me is we do have an electronic health record that has an automation tool that sends the screening forms to the patient ahead of time, and I'm able to view those ahead of time. And so, my particular we're pretty strict about no one comes into zone 3 without being screened. And so I can see right off the bat, has this person responded to the form? And if they haven't, my team is helpful enough and well trained enough that they'll give the patient a remote handset. And it's a Wi-Fi phone. And so I get to screen them right from the console where I'm sitting if I need to do that. So we've really figured out some novel workflow to kind of help and maintain HIPAA and privacy, and also be compliant, as we need to. For myself, I make it sound like I'm a one-man show, but as you hear, it's definitely with the help of some others around me.
Yeah, yeah. So definitely, it's not like you're back there by yourself and you have no help. You have another person that you can call on if something were to happen.
Yes, I do.
Yeah. Okay. And so, Kris, what about you and Randy? What does your layout look like? Is there an extra person per magnet? Is there 2 people? Is there 1 person? Can you guys elaborate on that?
Well, I think like everybody else right now, it just kind of depends on staffing. Ideally we'd have an extra person, but some days we have 2 scanners back to back that share a control room, and we'll typically have, 1 person on each scanner, and then the third person will come in maybe, in an hour. We've started utilizing tech aides across the street at our outpatient center, and that's been, they are worth their weight in gold. I highly recommend well-trained tech aides because, oh my goodness, that's such a huge help. But, if they call off or are taking a vacation day or something, we don't typically have enough staff to kind of shift over there. So it's been a little bit of the challenge. We're still utilizing travelers to kind of help with our staffing, but the way our site is designed specifically at the hospital is the patients go from the waiting room right into zone 3. And so we have them we're still using paper screening forms just because, the patients should be screened twice, and one should be, verbal and interactive. So they fill out that screening form in our waiting room. And then as we go to get them, we kind of review that screening form, and we're, doing the second screen as we're kind of coming into zone 3. It's not an optimal design, but we're in an older hospital that's been remodeled a bajillion times, and we're kind of making it work. So yeah, typically we've got that, an extra person, and sometimes we just don't. And it's not an optimal situation, but it's just one of those things you got to work with it right now, especially right now with the staffing shortages.
Right. And then, so Kris, do you guys run as well? Like, do you have set time slots, or is it like flexible? So maybe if you have a lumbar without, it's in a 15-minute time slot. And then if you've got an abdomen, it's in a 45, or how do your all's appointments work?
So our whole system runs on 45-minute time slots. Cardiacs get 2 time slots. And then we've got kind of inpatient slots kind of built in throughout the day, because we do everything from walkie-talkie outpatients to ventilated ICU patients to, level 1 trauma ER patients. And so who knows what the day's going to look like when you get there in the morning. So
Right.
I'm sure you can relate. So
I feel that in my bones. Yeah.
all of our appointment slots are 45 minutes, and then we've just got these kind of cushions built in where we can maybe squeeze in an ICU patient or something from the ER.
Yeah. Randy, what about you? I know you oversee 22 magnets. Is it the same? I'm assuming those are spread out across multiple facilities. So is it the same at every facility, or are they different? Can you elaborate a little bit more on what it's like for you all?
Yeah, thankfully on the west side of Corewell, because we're kind of merging with a couple other regions to become a larger entity. But on the west side, we have done a really good job of standardizing our MRI locations, and that includes staffing. So, ask me 3 or 4 handful of years ago, I would have said, well, we have 2 techs at this site, but then at this site, the techs are working single for half of the shift, or what have you. Very, very fortunate to have leadership that take the staffing model from the ACR very seriously. And so we do actually have 2 personnel per scanner at, I would say, probably 95% of the time. There is one location where there's one overnight technologist there, but similar to John's situation, they have trained personnel from other departments to be able to be there and assist, especially because when it's a children's hospital. So
Yeah.
it can be, that tech could scan 8 patients a night, they could scan 1. So
Yeah.
the staffing for that is so variable that they usually just pull in somebody else from another department. But if a technologist calls in, or if they can't find a technologist to cover a shift as the second person, they are pulling over somebody from X-ray or CT or something like that to act as that second person. Our main hospital, I call it the mothership, we do have tech aides that assist the technologists as well. And then actually at 2 of our locations, we have incorporated radiology nurses
Wow. That's
that
great.
are staffed in the area 5 days a week. And they
Yeah.
assist with screening and things like that as well.
Yeah. And so what do your all's time slots look like? Do they align with like Chris and John's where it's just we have 45 minutes, or do you guys kind of mold those to the exam?
They're a little bit molded to the exam now. But we have started utilizing, we have a list of certain exams that we've given our scheduling team and told them, these can be put in 30-minute slots.
Yeah.
Most of the other exams are still 45 minutes. I think a very rare occasion we have a 60-minute exam. There are some exams that require 2 time slots, like
Yeah.
what the other 2 were mentioning. But yeah, it is a little bit variable. But I would say the majority are still 45 minutes.
Yeah. Yeah. So I think one of the biggest differences, and I'm going to go off from the manual for just a minute so everybody can get a little bit more of an idea of how safety works at your all's facility. Randy, one of the things that I noticed that you said was you kind of get to oversee safety. So does that look like you're getting these implants ahead of time? They're not even showing up for their appointment until I look at this and say, hey, this is a good to go, and this is what scanner it can go on, and this is what conditions it can be done under. Is that what that looks like for you? Or is it like, hey, they're showing up the day of and now I've got to go? I mean, we know we can't filter through all of those, but can you tell me a little bit more about what that process looks like?
Yeah, we try to be as proactive as we can in screening, especially for those complex devices that take a lot of effort, a lot of time, potentially other people involved,
Yeah.
as far as physicians and vendors. Yeah, we try to do the best we can to be proactive with that. And so we will ask a abbreviated questionnaire at the point of scheduling. We'll ask about pacemakers, aneurysm clips, shunts, metal injuries, stimulators, things like that. And then if that patient answers yes to one of those questions, then it falls to a list that myself and my team monitor. And it used to be, until about 6 months ago, we were pausing scheduling until the MR safety review was done, so that we could make sure they're scheduled at the right location, the right day and
Yeah.
time, different things like that. And we're working our way back there. We
Yeah.
trialed something a little differently, but we're working our way back to um, that just making sure that the patient is scheduled at the right location at the right time the first time around.
Yeah, yeah. Now, John, I know you said that you guys have, I think you said an EMR where they send out the questionnaire and you get to review it. Is that something that you're doing in advance, or is that something you're doing day? And I don't want to assume with you because you're in an outpatient facility. Are you scanning active implants? I'm sure probably not pacemakers, but I'm assuming stimulators and other active implants
Yes.
might be.
So we do a fair amount of SCS. We have very active pain management services that refer to us. And no, the pacemakers do end up going to the tertiary hospital. And so those are all kept there, which I'm fine with. I have experience with those, and they can go ahead with those. But as far as the screening forms, yes, every single one. Now, we do have a centralized scheduling service. And so if something comes up, there's usually with now the age of teams, there's a message or something that comes up where, an unknown implant or something, and that will get cleared with the appropriate person. And then, they'll say, yes, it's okay to go to the imaging center, or it needs to, and field strength. And so we have a pretty
Yeah.
good team as far as that goes.
Good. And then Chris, is your facility, is it in line with this? Is it similar? Do you guys do things differently? Can you tell me about how you guys like scout out implants before they arrive, or do
We do. We utilize a central scheduling service like John does. And a few years ago, we hashed out like a decision tree so that the appropriate implants and devices can be sent to the appropriate site. So like if all of our pacemakers get scheduled on 1/5, just because we know that all of them can be scanned at 1/5. Some of them can be scanned at 3, but not all of them. So those all go to the 1/5 at the hospital. Any kind of stimulators are automatically set to the 1/5s. Anybody that needs like a transmit receive head coil for their particular device is automatically routed toward those sites. And then what we've done at my particular site is our outpatient center tends to be a little bit more controlled, tends to be a little bit, it's not necessarily slower, but it's just more controlled, a more predictable environment. So then that technologist is working out the schedule maybe 3 or 4 days ahead of time, looking at implants and devices. We have 2 slots a day that are devoted to outpatient pacers and defibrillators. So we know that we're going to look those up. And then we kind of look through the rest of the schedule and start kind of, we call it scrubbing the schedule. A lot of it, our EMR, Epic, we can pull some stuff from other healthcare organizations, but not always enough information. So we end up calling the patients a lot of the times and just trying to communicate with them and get more information. And then even if we've got all of the information that we need, we call the patients and remind them to, make sure that their stimulator is charged, that their remote is charged, that they bring all of that stuff with them, because it takes so long to get rescheduled. We're so busy. And so that, we really hate to lose that appointment slot, and we really hate to delay patient care. Sometimes we just have to. I mean, sometimes we just don't get the information, especially with us being level 1 trauma with, helicopters in the air. We're getting patients from, out of state and maybe 2 or 3 states away. And we're trying to track down their cardiologist from, Alabama to get the information that we need. So there is a lot of work that goes into it ahead of time. And I'm super excited that, CMS is maybe considering being able to bill for that time now. Those CPT codes coming out are exciting because there is so much behind the scenes that patients have no idea, like what goes on behind the scenes before they even get there.
Yeah, I agree. And so I want to talk about the CPT codes because I think that's important, but I want to pause for a second on something that you said. One of the common things that I'm seeing here is scanner utilization. So not only do we want to create a good experience for a patient, we want to have a good Press Ganey survey, but we also want to make sure that we're utilizing our scanners as much as we can. Those things make a lot of money, and we want them running as long as they can. And so when we have a patient show up and we say, hey, you came in and you don't have your simulator, or you don't have your remote, or you have your remote but it's not charged, or you had a pacemaker and you didn't tell us, my experience was always, it's really hard now to backfill that spot, because now I've eaten 20 minutes of this spot trying to get your x-rays or trying to get your stimulator programmed. And so it's really pertinent that there are these people that are doing this work, the legwork ahead of time. And I'm hopeful that the CPT codes that CMS saying we're going to reimburse for that will be kind of an initiative or a motivation for management to have a setup where it's like, we need to dedicate somebody to this. It is a, Randy, I think you can attest to this. Not all of us have 22 magnets, but it is a full-time job trying to research these implants, clear them, look up the conditions. Like you said, Kris, talk to the patients, be sure that you can, if we're doing a pacemaker and you've got to have a chest x-ray beforehand, I need you here a little bit early so you can go get that chest x-ray, or, whatever it is. But I'm very, very hopeful that with the CPT code reimbursement, that this will kind of be motivating to more directors, more radiology departments to say, we really should make this a full-time job. I think there are a lot of benefits to that. Do you guys agree?
I do. I think one of the things that's going to be interesting, and I'm hopeful, is that there will be some cross-fertilization across the continuum with things that we in MRI have already learned and run into by virtue of the types of implants, because there's a CPT code for positioning, and we all know who do it, that it's cochlear implants, that they have to be immobilized. And so there's a CPT code for that. Historically, I think my experience on the MR safety page was that, the techs were like, no way, no how, I'm not doing that. But if you have an ENT who's going to come in and maybe train facility, correctly or something, or the ENT who's going to do that. The other is, the heart rhythm experts. I mean, there's a lot of things centered around, do you do it with the iPad or not? And there's a lot of pushback about scope. But I think a lot of those are going to fall to training. And I think the MRI technologist is the fulcrum to a lot of those being potentiated with the supervision of those different services. And that's just my own perspective.
Yeah, I agree with that. And I think another thing, or I'm hopeful that another thing that we'll see too, and I don't know, maybe you guys can talk about this. Maybe we can get a little more risk benefits filled out by the radiologist. Maybe we can kind of guide them in that direction to say, hey, like, I know that this is extra work. Hopefully you guys all have an MRMD, but let's do this risk benefit and let's see if we can provide care to this patient who needs it. Let's see if we can give it to him safely. Is that something that you guys deal with? Do you all have MRMDs? Do you get any pushback on risk benefit? What is your experience with that?
We do. We've got a pretty solid MRMD at my facility at Grant. Where we run into issues is when he's not available. And I got a text message today from a technologist. I talked to 2 different radiologists and got 2 different answers. And she's texting me like, what do I do? And so, we talk about this a lot on the MR Safety Facebook page. I think we're all active on that page. Ultimately, it's the radiologist's call, which it is. But I think we can take our knowledge and what we know about the risks to the radiologist to give them, the information that they need. And I wish we had more. I wish that and I think Tobias talks about this too a lot, is that the training that the radiologists receive in MR safety is non-existent. And I just wish that we had, more radiologists with more solid MR skills, because we do, and especially, we see a lot of ballistic injuries at my site, and I've never analyzed so many bullets and shrapnel in my life as I have in the last 3 years. So, and it's just, and you have to, in my personal, it's crazy. But, I always go into it with, what can we do to get this patient scanned? What this patient said yes, what can we do to make that happen? Is it parameter manipulation? Is it coil manipulation? Is it positioning? Immobilization? What can we do to get this patient scanned? And generally we can. I mean, there's a few times we've run into a few bullets that are a little bit too close to the spinal cord, or maybe a little too close to, some vital organs. But typically, like we've been talking about, there's so much that goes on behind the scenes.
Yeah, I'm reminded of that Manny Canal saying, it's easy to say no, but it takes knowledge to be able to say yes. And I'm always reminded of that frequently when I get on that MR safety page, because you will see people ask questions and then the comments flood and it's like, no way I would do that. And I'm like, wait a second. And then typically I see one of you guys commenting on it and saying, well, wait a second.
I think one of the that is probably one of the best takeaways of seeing the influx of numbers of MRSO people who have become MRSO and MRS certified, is that we are starting to see a cultural change where the culture and the safety culture itself are benefiting from that knowledge. And, I think now, as you were describing, Kellye, there is a real need for us to have, not to simplify it down to an algorithm, but for every technologist to have the skill set that I should be presenting an executive summary of the 3 main things that we are faced with as far as the risks, and letting that radiologist make that informed decision. But we participate actively as their dependent provider, whose first act is to kind of summarize that for them. And I think, we're getting there little bit by little bit.
Yeah. Yeah, making some progress, I think. All right, I'm going to transition us away from this into something else that is another really, really hot topic, and that's remote scanning. We saw with the new ACR manual, there was a whole new section on that. Some ambiguity in that was talking about it's the radiologist's job to kind of oversee these offsites that they have no idea what's even going on. So I guess I'll start with, any of your facilities utilize remote scanning, and then we can talk about your opinions if you want.
There are none at my.
We do not.
We do not.
Randy?
No, the only way that I would say we are kind of involved in any sort of like remote anything is we have internal application specialists that
Okay.
will jump in using different platforms and be able to assist technologists remotely in that way, which as I was reading through the guidelines from the ACR, it kind of painted a very similar picture to what we would use it for within our system. So we won't necessarily use it for like a normal full 8-hour shift of somebody scanning remotely.
Right.
It's for those special situations where hey, I have this artifact, or I have this issue, I have this really hard exam I haven't done in a really long time, and then we can have one of our imaging specialists hop in via like a virtual cockpit or something like that, and be able
Yeah.
to assist the technologists. So in that
Yeah.
sense, we're, I guess, using remote scanning, but not in the sense that they're commercializing it for.
Yeah. I think that's invaluable, and I also think, and I feel like I'm probably going to get shot at for this, not from you guys, but from listeners. I think remote scanning is going to be able to provide care to patients that otherwise wouldn't get it. And I think that's what we are here for. We are here to, I mean, just like being MRSOs and doing risk assessments and trying to say, hey, what can we do to mitigate some of these things? Our job is to make sure that you get the care that you need. I think there are still some things that we have to work out with remote scanning. I think there are things that we're actively working on, but I think if we can nail this down, and if we can get a good process with this, and a safe process with this, I think remote scanning could be very, very beneficial to a lot of people, and not just patients, but to MR departments and facilities. And, I mean, I think there are a lot of benefits. If we can get this nailed down, I think there are a lot of benefits to remote scanning. It actually hurts my heart a little bit when I get on MR safety and I see people that are like, no way would I do that. And, I don't know. I think that it has the potential to be a very good thing. I think there are some things that we have to nail down and work out as far as safety goes, and how do we make sure these people are trained adequately. But I can see the value in it. Do you guys have it? Your opinion can differ. It won't hurt my feelings.
Well,
No, absolutely. I mean, it's here. And go ahead, John.
I was going to say, there's a lot of places in the country that it's happening, and I would venture to say that the majority currently are places where it's an outpatient imaging type of organization or model, and also a lot of the risks that they're undertaking, both legally and they're controlled in-house. They have the choice on the personnel and the configurations and things, and so there are iterations of it that are already actively happening, and I think have to come up with ways that we help one another, how it's going to evolve. Now, what I will say, and I'll give Kris some time here in just a moment, there are things that are happening both of the things I just commented about. We're trying to look at how the future of it is in tertiary academic centers or in hospital setting, but also like a practical example would be the breast screening MRIs, for example. If I'm the only male tech, and how do I convenience a female? Maybe there's a site where there's only a male technologist. So maybe we want to have a female radiographer go and position that patient in zone 4, and then we have an operator who isn't going to inconvenience and make that a pleasant experience for that patient who's already anxious and nervous. So there's a lots of reasons that it is part of improving patient care and safety.
Yeah. Kris, do you have something you want to add to that?
Yeah, this has been a topic of conversation for the last several years at the ASRT House of Delegates and Governance meeting, and a lot of what you see on the MR Safety Facebook page has been discussed there. People are just like, nope, not going to do it. Can't make me do it. This is bad. And it's here. Like John said, there are businesses that are created around it, and there are people that are doing it successfully. I just think we need to put some guardrails around it and establish some best practices. And I know there are organizations that are ripping on those And I mean, it's not going to go away. And so it's our job to kind of make sure that this is done safely, both from a patient standpoint and from a staffing standpoint. And I agree with what you said, Kellye, that this can be used to expand services, to patients that might not normally have access to a cardiac MR, or have access to, abdominal imaging or breast imaging and things like that. So I mean, I think it's here. I mean, we can't stop it, so we might as well, help control it and help do it safely.
Yeah. So I'm going to use that to segue into another thing that is kind of new in the ACR manual, but that is the guidelines for level 1 and level 2 training. So I guess personally, I love the chart. So John, when you said at the beginning, you love the appendices, my favorite part too, such a valuable resource. If you've not looked at the appendices of the new ACR manual, you should print one of those off and go look at it right now, because so good. So what do you guys think about the new recommendations for level 1 and level 2 safety training?
I think it's well thought out. I think they took a lot of feedback and they made things actionable and they organized them effectively. So I can tell that there were people who paid attention to the feedback and the response. Is it ever gonna? I think it's a struggle because we still limit it to 2 things, level 1 and level 2. And I think there's always going to be shades and nuances that don't necessarily encompass that particular person being there. I'm not gonna, be shy about it, but anesthesia and an error started off with the Columbini incident. It is always going to be a struggle for me to see anesthesia as level 2 people, but they need to be. And so, that's the part where it's a good kind of fear. It's the respect for safety and for the patient concern. I think they're good, in my opinion.
Yeah. What about Randy, Kris? What do you guys have to say?
Yeah, go ahead, Kris.
Go ahead. So I mean, that chart is one of my favorite things about the new manual, because at my organization, just at my hospital, we've got 3 magnets, but we've got hospitals and outpatient centers and open scanners and techs everywhere, and just trying to coordinate all of that training and trying to standardize just our onboarding process. What do people really need to know? And we just had a huge Kaizen event about standardizing our onboarding and competencies, and just being able to have that black and white list of here's what they need to know. Here's what constitutes level 1 and here's what constitutes level 2. And it's particularly interesting in the ICU nurse versus the bed incident in California last year. Allegedly that ICU nurse was level 2 trained. Well, there's no way that she was level 2 trained. And you can't just hit somebody with a scepter and say, boom, you're level 2. So
if it's that easy, I would like to be an MRMD, please.
Yeah, right.
I'll take that too. But so this just
with
lays
the paycheck,
out
with the paycheck.
Oh, absolutely. But this just lays out in black and white. If you think you're level 2, then here's what you need to know. And that's one of my favorite things about the whole thing.
Randy, do you have anything to add?
I'm just going to echo everything that Kris and John said as far as the chart. I was tickled pink to see that. That's but another one of my responsibilities within our system is to come up with the level 1 and level 2 training modules. And so I build these things, and I certainly didn't start from scratch. We've had them in place for quite a while before I was in this role, to have a checklist, for each different level of training. It does a couple of things. One, it really does kind of lay out the expectation of what truly a level 2 person should be versus a level 1, but also it can validate like myself at my facilities. Like I looked at that list and I'm like, okay, yep, got that, yep. So it kind of almost validates, like, all right, cool, I'm doing something right. Having said all that, I do like at the very end of that section when it's talking about level 1, level 2 training, where it says that you might have, there's opportunity to basically have like a hybrid, an in-between, level 1, level 2 training. And I think that is important to call out, because there are just as Kris and John said, there's so many different, people, departments, that are close to the MRI department. I mentioned that at a couple of our facilities, we have radiology nurses that are staffed in the space, 5 days a week. They primarily stay out in the holding area in zone 2. They have access into zone 3. They do not have badge access into zone 4.
Yeah.
So, but they also help with, preparing our patients, screening our patients, wanding our patients. And so they're kind of almost like I call them like a level 1A or something like that.
Yeah.
You can kind of
Yeah.
customize them however way you need to. And I think that was important for the ACR manual to call out.
Yeah, I agree. And I wonder at least if some of the driving factor behind that was all of these alternative MR environments. If they said, hey, like has evolved, it's the modality, but the complexity of the patients that we're taking care of. But since MR is evolving, we can kind of see a need for an involvement of how we're going to designate personnel, as in like maybe you're a level 1A and so you can be just these are just examples. I hope nobody listening to this like, well, Kellye said, but maybe you're a level 1A and so you can just be responsible for you in zone 4, or maybe you're a level 1B and so you get a little bit more responsibility. But I love that we've all kind of recognized that this modality is evolving and more safety is evolving, and we need to evolve our practices with that. So one of the other things that I saw in the manual that I really loved was an emphasis on pre-entering zone 4, the full stop final check, how they changed it from, there's like a regular and then an augmented, and then they had that section on zone 4 exam prep and completion. I can't help but wonder, we've seen so many, I feel like, I hate to say this, I feel like every day I get on social media, it's like, oh, it's something else stuck to a magnet. Oh, a stretcher. Oh, a gun. And I can't help but wonder if they're seeing that too. And they're like, well, we should do something about this. What can we do? Did the addition of those two, well, the full stop final check was there, but they did make a routine and an augmented. And then this zone 4 prep and completion was pretty new, I think. Did the addition of those two, was it not new? Did the addition of those two things, did that change anything for you guys? Are you all changing your processes? Did you already have a process in place and this was just validation that, hey, we're doing the right thing?
Before I answer you, Kellye, I'd like to just step back because you said something really important and really powerful. And I'd like to tie those last two thoughts together. Okay. So, and this is going to be a little visioning for me to share with you. So we talked about the level 1, level 2, and we talked about, the roles that are in play and the personnel that are involved, but this also ties to something Randy said. So see a vision of us moving in the tertiary care hospital to where it's not complicated to do pacemaker care, or it's not complicated to do anesthesia care, because perhaps the MR technologists are removed from zone 3 and zone 4 altogether, and we leave the appropriate nursing and nurse practitioners to do those things that are those levels that people don't want to participate in or don't have as part of their scope. And that's the premier level of care that's supposed to be there, where we're currently using 2 different roles to do that. I see that as a possibility as the technology allows it. And as I'm also certified in patient safety. So I kind of see the continuum and the possibilities there. But now to answer your question about the full stop, the thing is for me, that's one of the best things I like about my configuration is I bring my walkie-talkie outpatients right to my control desk. And I have my EMR sitting there with their screening form, and I physically take the time to make them sit next to me. And we go through and I do overview what's inside the body, what's outside the body, and any random possibilities for metal fragments, gunshots, that kind of thing. But it is essentially a physical stop that they sit next to me, and I ask them to participate with that, confirm who they are, confirm what the exam is that we're going to do. And the patients have terrific feedback with that. They feel like that's professional. They feel like that is very careful, and the feedback has been phenomenal.
Yeah, I love that. What about you guys, Kris, Randy? What does your process look like for a full stop final check? Did anything change with with the revisions for the manual?
Nothing changed for us. We were already doing full stop and final check. We put a particular emphasis on it because we did have, a couple of hearing aids work their way in. We've had, our FMD fortunately has caught a couple of house arrest bracelet anklet kind of things that people try to sneak in. But I think that the routine and the augmented, it is what it is. But I think the routine and the augmented was a good acknowledgement that not all of our patients are the same. Not all of our patients are walkie-talkie and can walk on in. The ICU patients, who knows what they've got stuck under those sheets? Is it a fork? Is it their cell phone? Is it, their purse, their watch, whatever? So yeah, I mean, we've got a whole gradient of necessary full stop and final checks. So yeah, it's just brought some extra attention to it, just, to kind of make sure that we're really doing it and that we're doing it well.
Randy,
Kris,
do you
I
have anything to
appreciate
add?
your yeah, Kris, I appreciate your word usage there. I caught that. The whole gradient
Gradient.
of
See what I did there?
Spoken like a true MRSO.
yes, I think that it hasn't changed anything yet, but one of the things that we did last year, we did something within our system called a call to action, an MR safety call to action, where we heard a lot of feedback from everybody within our sites. And one of the action items that we took away from that is incorporating more, how do you want to say, I guess, a more purposeful full stop timeout. And I think that's what this really allows us to do, is it allows us to be more purposeful in that full stop timeout instead of just a kind of a casual, as you're walking towards zone 4, oh, hey, yeah, do you, name, date of birth, you have this.
Yeah.
It's a, the I think what the ACR manual is hopefully going to inspire more places to do is to create an environment where it is more purposeful, like exactly what John was just saying. You have a dedicated area to sit your patient down, go over the screening history with them, and as opposed to just verbally doing it as you're walking towards zone 4. The other thing that I think is really important with this is the visuals, are the visual examples that are provided by the ACR manual, but also just understanding, for sites that are out there. If you're at a hospital facility, see if you can make your way into one of the OR suites sometime. There's typically, at least in our facilities. Yeah. Well, there's a gatekeeper, but there's also typically they have a poster on the border, at least at our facilities they do, of a full stop timeout, and it is thorough. And they have to do it before every single procedure. And it is like clockwork. And that is something that I really want to aspire to incorporate into our MRI departments, for multiple reasons. One, standardization, but two, it also, I've thought this for several years now. If patients thought of MRI more like surgery, they would be more apt to comply with what we're doing, as far as having to change their clothes and having to, ask them questions about their history multiple times, different things like that. I mean, think about it. There's so many similarities in a prep for a surgery that, you go through all this stuff and you don't really think about it because it's just part of the gig. It's just part of the prep process. Whereas with MRI, it's all over the place. So I think it's very important for us to have things like physical posters, signage, however you want to set it up. You have to kind of create the environment to breed the culture that you want, the
outcome.
the outcome that you want. So that way, if a technologist is asking you these questions, or asking you to change your clothes, they're, instead of just having to basically plead their case and defend themselves, they have things that they can point to within the department that says, well, here, if you see this is our policy, this is what we're supposed to do. So it's support for them as well.
Right. I loved your comparison to surgery. And I kind of feel like what you're doing, Randy, is like the pre op appointment, right? It's, hey, like we have to go through all of these things, or you physically cannot have this exam. And so I'm hopeful with CMS saying we're going to reimburse for some of this stuff that other facilities will kind of see that the same way as like you have to have your
Mhm.
pre op or your pre MRI appointment, which is not an appointment, but a phone call or whatever, before you can come in and have your exam. Like we have to start treating it with the importance that it requires so that our patients can see, hey, this is serious. So
Yeah.
thank you for that. I think that's a really great comparison. I'm going to wrap up with one more question for each of you. And my question is, what is the biggest challenge that you currently face regarding MR safety?
Only one?
You can give me multiple if you want.
It's patients are living longer, people are having more interventions, there's more devices, there's more, when I first started an MRI, just about 30 years ago, just about the same time John did, we didn't scan patients that were on
Yeah.
IVs or that had chest tubes or were on ventilators. Our sick patients weren't that sick. And
Right.
now, just even our outpatients are coming with multiple active devices, and just navigating all of that, and the inconsistent labeling is what drives me crazy. I wish, we've got
Yeah.
consistent labeling for nutrition. If you flip a box of cornflakes over, you know what that says,
Yes.
you know what that means. Why can't we have that, something like that for
MR.
implants and devices? Because this
I
labeling,
agree.
it's almost like a different language sometimes.
Yes.
Yeah. Yeah. I agree.
Yes. Very good
All
point.
right. What about you two,
I
John,
think for
Randy?
me,
Anything?
as much as I expressed a little bit of fear about anesthesia, I'm a little envious sometimes of their culture and their design, in that I really wish that there was a Manny Canal at every site where you had an engaged radiologist who wanted to come and, really understand everything that's going on. And I think that one of the biggest challenges is that
Yeah.
like you had mentioned about Tobias saying, it's not built into their education. And they do get an interest, just like we as technologists get an interest, but I think it's going to take some time. But I'd rather have an engaged radiologist who maybe wants to be on site. That's not what culture is offering them, and I'm really hopeful that maybe somewhere along the line that'll change.
Yeah, me too. Randy, what about you?
I'm glad I had a backup because that was kind of tied with I was kind of tied with what I'm going to say and what John just said. And John, you said it perfectly. I'm glad I'm glad that I had a backup. For me, I would have to say lack of standardization of practices is really, I think, the biggest challenge that we face with MR safety. Just an example of that, I can have a patient come to one of my facilities. We've even struggled with standardization within the locations that we have. We've done
Yeah.
a much better
Yeah.
job the last couple of years of doing that. But, just going back to changing your patients out of their clothes, you can only, um, you know, MRI facility down the street or down the road or in the next town over isn't
Yeah.
isn't following that. So
Yeah.
you have a patient show up at your facility, you ask them to change out of their clothes, and they tell you, well, I didn't have to do that when I went over here and had this MRI. Why are you making me do it? And then
Yeah.
then it gets into that whole, you have to defend yourself, you have to explain why and different things like that.
Yeah.
And again, I go back to surgery. You show what is one of the first things they have you do once they get back to get ready for your surgery. Take off your clothes. And nobody says anything about it. Take off all your rings, take off all your stuff. Well, I'm having a colonoscopy. Why do I need to take off my wedding ring? Well, but I don't question it because it's standard every single
Yeah.
time. And I think until we get to that point where there is some sort of a regulatory mandate or requirement to have these standard practices in place, I think we're going to be climbing an uphill battle.
Yeah. Yeah, I agree. Randy, Kris, John, it has been so amazing to get to just sit here and chat about MR safety with you guys. I appreciate you all coming on and doing this. And I'm sure that our listeners are going to get a lot out of this too. MR Safety Week 2024, but this is not the start or the ending. You know, like if you're very serious about this, there's continually something that you can learn. So I appreciate your all's voices, your expertise coming on here and chatting. And I hope that our listeners do as well. So thank you guys so much for joining us.
Thank you very
Well,
much.
thank you for having us.